Welcome to live case for CTO session, which will continue about 90 minutes. We prepared 2 live cases from Japan and Korea for 30 minutes for each case, and we also have 10 minutes featured lecture too. As you can see, the program, I'm H.S. Kim from Messenger Hospital. My co-moderator is Dr. Satoru Otsuji from Japan. We have really global eminent panelists, Dr. Jungo Furuya, Dr. Yuji Hamazaki, Dr. Myeong-Ho, Dr. Hsien-Li, Dr. Dong-Bin Kim, Dr. Tse-Min, Dr. Sanghoon, Shin, Dr. Myeong-Ho, Yoon. Let's start. First live case from Japan, Professor Maoto Habara from Toyohashi Heart Center. Dr. Habara,
Okay.
Yeah. Let's start.
Can you hear me?
Yeah, we can hear you.
Okay, sorry. Yeah. Thank you so much, Kim Sensei. This is a great privilege for us to participate in this esteemed conference as one of the live site. And so today we prepared one case of the LAD CTO. Can I let us to perform a case presentation? Can you see the slide?
Yes, please.
Okay. This case is 70 years male, and the target is LAD CTO. That is very short. This case came to our hospital about 1 month before with worsening chest pain, and after that, that's what I will show the angiogram. The RCA was a severe stenosis with positive remodeling, and LAD was CTO. Syntax score was LAD CTO was 3, and today's target is LAD. Ejection fraction is 48. Next. This is a cardiac CT. The CT segment is very, very short, and that includes diagonal branch. Diagonal branch is just distal of the CTO site. And so there is a calcified plaque around the distal segment. Next. And this is the RCA segment. So there is a very, very severe stenosis and very positive remodeling. And maybe so we thought about slow flow or no flow phenomenon. Next. And this is angiography at the baseline. You can see the tight stenosis as distal RCA near the bifurcation region. And then next. And this is a CTO. This is just LAD. And so we can see some antegrade flow. That's why, so at that time, we thought maybe this LAD looks subtotal lesion. And RCA was a very positive remodeling, so that also we decided to treat LAD first because this vessel is a jeopardized collateral site. That's why, so I advanced it, so choose PCI for LAD at first. Next. And so this is a PCR for the LAD. You can see the distal segment that is includes your bifurcation and a very, very short. And RCA is also very tight stenosis. That's why, so this case we only focus for the antegrade approach. And then next. And so we thought that there is a micro channel. However, chip injection cannot see the channel, and XTR was failed. So that so we step up to the Gaia next to 2, Gaia next to 4, and of course antegrade entry of the CTO was ambiguous. So that so we performed IVAS guided puncture with Gaia next to 2, and so this is during the procedure. This is a guide wire is very close to the distal end. However, little bit there is a different course or something, so we can see some collateral, so the right side of the calcified plaque, and that's a wide guide wire tip. Can you see that? So we cannot confirm that this course is true or not. So that so it was a little bit dangerous to continue with a stiff wire. So at this time, we decided to treat RCA with a fine filter up or something, filter wire. And so finally, so fortunately, so we can treat it the RCA without slow flow or no flow phenomenon. And so today we tackle to the LAD CTO. And so I will show the today's first shot. So this is today's first shot. Can you see collateral some RCA to the LAD? And so this is next. This is a bidirectional angiography. CTO segment is very short. However, so the distal segment is a little bit ambiguous, and there is including a bifurcation. This is our case. Please discuss the case.
Yeah, it is definitely not so easy because of blunt and with side branch. Can we get some insight from
that,
panels?
So we only have 30 minutes, so that so can I talk about the procedure so far?
Okay, please.
Okay. So that after that, please discuss antegrade or retrograde. So, however, so we are decided to perform a retrograde approach because CTO this segment is not so ambiguous, and in addition, so there is a collateral, and so this is a second attempt case. So next, I already performed a chip injection with some channel. And this is one channel. So, like there are so many collateral channels by the angiography. However, in those cases, are very difficult to negotiate, unfortunately. And this channel I used so zealously. However, so failed. Next. So that so quickly I change it to the distal one. Next. So we can see sleeve one, but so this is a more distal one, most distal one. And so there is a connection. However, the guide wire slow and the XCR cannot negotiate it. And so finally, so this is the second one. Second one looks good. However, this is also there is a severe bending at you can see LAO. There is some bending, and unfortunately, this channel is also cannot fail. It was failed. 分かってるね。で next. Next. And so this is next. This cannot and so we can see one channel. So just before this branch, so RLO is completely overlapped. However, so LAO we can see a little bit proximal site. Coming to LAD, you can see that this is a chip injection with double lumen catheter, and so this is a guide wire advanced to the side branch, and this is a chip injection.
Yeah, that's right.
Yes, yeah. And unfortunately, this is also difficult. And this is the SO03, and there's a very, very tiny channel. And this is also channel SO03. However, this is another channel. Next. And so we finally selected XCR. XCR, next. Mada, next. Yeah, this one. XCR can advance towards to LED. However, so any microcatheter cannot advance because that is a very, very tiny channel. And so next, I performed the anchor balloon technique and so changed the design. Design microcatheter could be advanced more proximally. Next. However, so you can see the proximal site, the bending portion cannot advance. Mm-hmm. So I selected this is a Corsair XS. And the guide wire fortunately negotiated to the D3 diagonal branch so that so we can advance the microcatheter to the diagonal branch and coming back. And so this is a cyan black. and a little bit chip injection. Finally, we can reach it to the already distal CTO segment. This is the procedure so far.
Yeah. How long did it take?
It's about 1 hour.
1 hour.
1 hour, 15 minutes.
1 hour
15
and
minutes.
surfing for about 5 septal channels. Finally, you succeeded in finding the right way toward the mid-LAD. Is there a comment from the panels, Dr. Kao and Dr. Otsuji?
Well, you are very persistent on the septals. Congratulate. But I think I can see ipsilateral epicardial from the diagonal to the ipsilateral diagonal.
Yeah, thank
and
you so much.
also some epicardial coming from the cornus branch or the RV branch of the RCA. So sometimes these other alternatives can also be considered.
Maybe yes, but so at first there is so many septal channels. That's why we thought we can advance the guide wire more easily. So that is my mistake.
Personally, I feel always it is more difficult to find the septal channel from the right side toward the left side because the origin is very complicated. In other words, the branching point from PDA is very difficult to delineate. So in our previous images, he found a right one
next to
just behind the previous try one. But actually, the starting point is proximal part, but actually the direction is downward, distal part. So it is crossed between many fine branches. That is really difficult thing to find the true septal channels from PDA toward LAD. But he finally succeeded after 4 trials. It's wonderful. Okay, what is your further plan to penetrate a little bit short CTO segment?
Yeah.
But the entry point is ambiguous with side branches on both sides.
Yeah, so that at first I negotiated the guide warrior to anti-gladly, and according to the guide warrior cross, I negotiated. I will decide to which is better to puncture retrograde side or anti-glade side. なんでスパイダーね。はい、もういいよ。戻して。
So he
I was
probably
missed
used IVUS guided proximal stump puncture.
Yeah, maybe it is. Yeah. Okay. So this is a. Can you see IVUS?
Yes.
Yeah. This is the. なんか前回の穴がある。
So you already checked the entrance?
No.
The previous, previous angio.
Previous, yeah.
Yes,
Last time, so we checked it. So that.
Is it ante-owl system from Thermo?
Yeah,
Dr. Habara,
ante-old, yes.
Dr. Habara, do you perform a chip injection from a retrograde side?
Yeah, I tried. However, so we cannot pulling blood from the guiding catheter because that's a very, very tiny channel. So that we gave up to chip injection from retrogradely.
So in this situation, I think the antegrade wire is better than the direct retrograde crossing because of the in the lesion calcium in the CTO segment, and we have this patient has a big diagonal branch. So if they doing the direct retrograde crossing, maybe we lose the big diagonal branch.
Yeah. That's
So
right.
the type of the extended reverse cut. So we should do the directed reverse cut in this case. I want to do.
Okay, yes.
Can you explain the guiding character size? And I think you used one is the radial approach, one is the femoral approach. Why use the radial approach?
That's right. Yeah, one is unplugged catheter from the right radial artery, and we selected unplugged L1 with tight hole. And from femoral artery, we selected 8 French guiding catheter, and so that is SPB 3.75.
So what guide wire do you use now?
Now this is a guidance next to.
Is it, you decide the guide wire by the IBUS finding?
Yes. Yeah, but so that is a very, very short segment of the CTO. That's why if we puncture after that, advanced microcatheter and change the guide wire may be a little bit difficult. That's why I selected.
In this situation, the conquest is better than the Gaia.
Really?
To direct the direction. Because
direction.
Because the Gaia is a tip is flexible than the conquest, and maybe the deviation of the tip.
True lumen is 11 or 10 o'clock.
Yes.
Yeah, 11 and 10
Guide
o'clock.
wire is
Yeah.
near to the just intimate of true lumen.
Yeah, Can you see?
Yeah.
Guide wire is looks not so bad.
Yeah, good position.
Yeah. Thank you so
More
much.
center is better.
Not yet central.
But anyway, in the vessel, within the vessel is okay.
Yeah. Okay. で、レトロのワイヤーをバイプレーンして。で、エスペラックスで測った角度にしてみて。あ、そうか。じゃあいいよ。じゃあいい。バイプレーンでいい。Retrograde is now cyan black. Anyway, so to be as a marker, I negotiated the retrograde wire more proximally, if possible. Yeah, こうなんだよな。こうなんだよな。
Because maybe this part has a caution, so.
Yeah, I think this is a diagonal branch.
Yeah.
So we have two. The guide wire advanced to the diagonal branch. Okay, so
The diagonal is the proximal diagonal.
yeah, that is a proximal diagonal branch. So you can we can. So the guide wire should be advanced more upper side from the antegrade.
First, advance retro microcatheter more.
Or the snare in the diagonal.
No.
Yeah,
But so
Catch
this
the
is
retrograde wire.
no. This is another diagonal.
Oh, okay. I see.
Yeah.
I'm not.
IBUS is
I'm sorry.
proximal diagonal. Yeah.
I'm sorry.
Diagonal 1 and 2 are very close to each other.
Yes, that's right. So yeah.
Or this is a branch of that first diagonal branch.
Because so cardiac CT shows we can confirm. So there is a two diagonal branch, and so one is a CTO proximal, and one is a CTO distal. 多分違うよね。ちょ待って、じゃあ見せてあげて。もしこれが一緒やった
I
ら。
cannot differentiate the first and the second diagonal.
Yeah, but
by the underground
this is
now.
Can you see IBUS? Can you see IBUS?
Okay.
Yeah, if the guide wire is so same one,
Yeah, you can see. Yeah.
we can see two wire.
Okay.
But this area.
Okay.
Right.
そこや。Yeah, so that we cannot see two guide wire.
Right.
Yeah, that's right. So this is a completely different one.
I see.
こっちはでもいやクラニアルは？いやクラニアル右行かなあかんや。これが右行かへんね。 いやだってこれで通ってもリディスタルYeah, this is also little bit difficult situation.
But now you can handle the guide wire and along to the distal retrograde guide wire.
No,
It's a better situation than before.
Yeah, that's right. Yeah. So we have a retrograde wire. That's why it's more better than previous session.
You go for the bending portion of your retrograde wire, because that's supposedly the bifurcation of the diagonal and LAD.
Yeah.
I remember that the heavy classification is positioned to the opposite side of the diagonal, so you'd better to direct the wire to the diagonal.
To the diagonal
Yeah.
branch? Okay. Hopefully. Oh,
Okay. A little bit turn.
I don't know true or not. I'm not sure. 待って。
Maybe in the D2.
D2.
Yeah, D2 direction.
Just slightly withdraw and redirection toward distal mid LAD.
Yeah. But I think more proximally right side is better. Hopefully. これは違う。これ違うね。
Looks better.
Yeah, this is not so bad.
Looks better on both angles.
Guide wire ある?
So good. I think it's good. It's good direction.
Yeah, I think to avoid a shortcut at the bifurcation,
Yes.
retrograde approach is better.
Better, yeah.
Yeah, in this situation. What do you think?
Okay.
Yeah, you have already good
Guide wire is
landmark
also-
for
yeah.
retrograde wiring.
Yes. じゃあガイアネクスト2ちょうだい。
So you remove the wire to the second diagonal and change the wire to the stiff one from retrograde.
Yes. いや、そうなっちゃうな。そうなっちゃうな。そうなっちゃうな。
Maybe I think that the diagonal branch bifurcation is too steep. So if you get straight and you can get the diagonal with the reverse wire technique, and how do you think?
Yeah, that is one choice. This is one choice. Yeah. So, yeah.
Or you can keep the retrograde wire in the D2 and then change for a dual lumen catheter.
Oh yeah.
Yeah.
So you can save
however, so, yeah,
all of
this-
these
yeah,
diagonals.
this is one choice. However, that was very tough to advance microcassette to the LED. That's why. So I think that's almost impossible to advance a double lumen cassette from the retrograde.
I'm not sure too that double lumen catheter can pass this tiny channel.
Not through retrograde, but through antegrade. He mentioned antegrade usage of multi-channel catheter because now the anti-wire can access easily to D2. That's when you put the anti-wire into D2 and let alone, and then you can use another anti-wire under the Sasuke to negotiate antegrade penetration. But I think if you focus a little bit more, because anti-wire direction is good, you can find true distal lumen.
or the wire escalation from the antegrade.
Okay, yeah, I will select so retrograde wire change.
Really?
Anyway, yes, try.
But then you have to remove the D2 wire, right?
Yes, of course. 今レトロはあれだな。
Remember, the retrograde microcatheter had been advanced into the diagonal too, right? So I think distal to the D2 bifurcation, actually the lumen is wide open.
Yeah, not so wide. I think that's
Not so
angiography. Not so. I think.
There's a huge friction on the retro microcatheter.
Anyway, I advance.
Also again,
To the-
yeah, okay.
Okay, this is completely covered
Then
by
pu-
microcatheter.
yeah, then puncture the retro catheter with anti-wire.
Okay,
Not
that is
difficult.
so. Yeah, next for まちょっとマイクロの曲げ替えるわ。ちょっと曲げがいるんだよ多分。あそこすげえ曲がってんだよ多分。すごいショートの距離で。
That means if you use the stiff wire from the retro, maybe you may create the large horse lumen.
Okay, I will change a little bit curve of the
Antegrade wire.
antegrade wire, little bit curve. I'd like to more diagonal side.
How about using the more stiff wire like Gaia force?
Yeah, if that's so, this is a field, I will change to the guy next door.
Current wire is a guy next to 2.
This is a guy next to. アイバス一応見といてね。同じ入り口に入るか。あ、このコース。あ、違う。そう、ここで上行ってほしいね。でも頂上だよ、ここ頂上だよ。
I think the tip deflection is too big. So, do you think that you need another stiff guide wire?
Yeah, I will change next floor. But a little bit.
But
あったな。でもこれどっち？どっち？
maybe
Going to the
the
diagonal.
little corsair change the bifurcation.
いや、これね、抵抗があった。いや。じゃあ、ガイネクスト4ちょうだい。あ、これは？これ違うな。これ D の。あそこがなっちゃうね。ちゃうねんちゃうねん。こう上に行かなあかん。あ、もうここにスペースできたな。
There's, it is time to change through the
Okay, sorry,
retrograde
sorry.
wire.
Yeah.
Yeah, because there is some space anti-Y. Thus,
Yeah.
it is easier to advance retro wire.
これどこにあるアンテナワイヤー？あれアンテナワイヤーはこう来て、ああだからLED 方向行ってんねんな。OK。 どっち？今レトロってこっちか。じゃあ NEXT 2。ちょっとガイド見しといてよ、右のガイドね。はい、このコース、はい、ちょうだい。
What are you going to do next?
Retrograde function with the guy next to.
How about think the antegrade wire advancing and small balloon?
Yeah, but because this is a very, very short segment of the CTO, that's why.
Length is actually about 5 millimeter.
Yeah.
It's not so difficult. Just manipulate the retro wire, then you can easily find the space
Hopefully.
made by anti-wire.
Which change the retro wire?
Next to.
Wire next to.
Yes.
We can see the wire controllability is worse than the antegrade.
Actually, yes. Absolutely.
That's why I want to
Yeah.
use antegrade to stick wire.
Okay.
これ見て、ちょっとアイバス見して。どこに来てる？お、なんか2つある？あ、違うわ。これはもちろんあれだ。アンチのがいいや。そりゃそうや。いやこれね、ちょっとこのクラニアルが多分な使えないんだよ。
There are 2 wire shadows.
Yeah.
じゃあ1個多分あれサブやね。あ、間違えた。これアンテだ。
Okay.
この短い距離でここ当たる。
Yeah.
なんかあそこワイヤー見えんね。サブにね。
12 o'clock, you mean?
Maybe yes. Unfortunately. どっちもむずいし。
Okay.
Nice.
Check another angle.
No, completely different. やっぱじゃあ安定。
I think the wire controllability is much better from the antegrade.
Yeah,
Of course.
of course.
Of course. But if you have a dual lumen catheter, then story
Okay.
will be different.
You mean
Okay,
from
okay,
retrograde?
But
Okay, it's time
Yeah,
to
okay,
switch
sorry,
it to
sorry,
the
sorry.
Severance
Yeah.
Hospital,
Yeah, please,
Korea.
yes. 抜いて。
After completion of Severance Hospital, we are going back to you to get the final result. Dr. Kim,
Okay, can you hear me?
yes, please explain your case.
Yes, yeah. Welcome to Yonsei classroom. So good afternoon, everyone. So I am BK Kim. and also let me introduce our team is Professor Sung-Jin Hong, and also our fellow is Sono Kim and John. So today's case is LAD CTO. So the Professor Hong,
Yes.
please show us today's case.
Yes, we prepared this LAD CTO cases, interesting but very challenging cases. He complained chest pain for 2 years. Next. Our patient is a 69-year-old man, and he had no other medical histories, but he had hyperlipidemia. Next. On echo images, the ejection fraction was normal, and on MIBI scan, there was a reversible perfusion defect in anterior and anterior septal wall. Next. 2 months ago, he took the angiography, and you can see the distal ICA has some significant disease, and the collaterals to the LAD and diagonal branches. Next. This is the left system. You can see that there is some LAD CTO from the LAD ostium, and the subcomplex artery has some diseases, and just the left main disease, the distal part of the left main, there is some occluded segment. Next. And you can see the apicodal view. We can not sure that this is the LAD ostium, but you can see several branches from the left main. Next. This is the spider view, and you can also see that some diseases left main, and just the distal part of the left main, you can see some branches, and we suspect that this is the LAD ostium branch. Next. So we took the CT angiography. The occluded segment is around 40 millimeters, and you can see from the LAD ostium, the left lower figures, you can see the very heavily calcified calcifications on the LAD ostiums, and on the distal part of the CTO segment, you can see very heavily calcified lesions. Okay. This is the LAD ostium part of the CT images. Just left main disease segment, the branch was, we can confirm that this is the LAD ostium lesions. Okay, this is the final images.
Okay, so this patient is a LAD CTO, and vessel diameters is a little bit small, and also even though we can see some location of the LAD os, however, it's not clear, especially on the cranial view. If we can see the CT scan analysis, anyway, very big calcification region in left main, and then circumflex and LAD os, suggestive of the LAD ostium, was started. So could you show us the spider view on slide? Yes, this is the spider view. Is definitely many branches near the circumflex ostium or LAD. Yeah, so and also because of some diseased portion of left main, the acute bending is more severe because of the left main. So this is the case summary.
Can you see the images taken today?
Okay, so typically we prepare both femoral and 7 branchy. This is today the angiogram is areocranial and spider view. Next one is areocaudal and areocranial view. 다시 보여줘 그냥. 예. Okay. So on the area caudal view is a proportion, maybe the definitely LAD. Yeah. And also the RCA from collateral is filling the diagonal and LAD. And also we can see the some calcification region just before the distal CTO stump.
Because of time limit, would you please explain your plan?
Okay, so from the CT scan, anyway, some middle CTO portion, definitely we cannot know is the real CTO length is more than 40 or not because of the middle calcified regions we can see, and also the vessel diameter was not so large. So anyway, the first one is that we find the austere portion in antegrade, and then antegrade first. Maybe this case is also needed some retrograde approach. We can see some promising septal channel. Next one. Next one. Yeah. So this is the circumflex wiring, and then we can check the IBUS is a real LAD austere location. But in the this is the some wire movement of LAD. However, this is very acute bending, so not easy to. Initially we studied circumflex IBUS. IBUS 보여주세요. Initial IBUS. Okay, this is the pullback from the circumflex to left main. This is the OM branch. And then some small branch coming. And this one is the LAD location. Is from the spider view is we can see the intermediate branch just proximally. LAD austere region was suspected. So next one. Next one. Okay. So on the spider view, the bending is very severe. Next one. So not easy to approach this portion. So and also the slippage, and this is the next one. However, this branch is the some intermediate branch previously mentioned is just before the. Just after the LAD austere region. So based on this wire as the marker wire. Positive. Next one. Yeah. Minus. Okay. Next one. So from the cranial view, we cannot know. However, the caudal view is definitely this is not LAD. Next one. And I used the one more wire. This is the Hsien ES wire. So some bended portion, as everybody can see, is or maybe this portion would be the start of the LAD. Next one. This is the cranial view. So many times I tried. Next one. And then this is the I will took again of the LAD view is. Just before, so next one. And then finally, this is the Hsien black. Next one. And definitely the wire tip is headed to the calcification of the LAD portion. And then we check the IBUS. 와이어 놓고 찍은 IBUS. Okay, so from the 1 o'clock is LAD wire approaching. So in the LAD austere branch is definitely would be okay. So and then anyway, I firstly try the antegrade approach. Yeah, but the time saving, I also already checked the septal channel from the RCA collateral. That's okay. So, okay, this is the NG 보여주세요. 네. This is the RAU view. And then the previous wire is XTA, and also I just stopped this portion, the wire movement or advancement. Well, it's not so bad. So the antegrade wiring escalation. Next, I'm going to use the Gaia next one.
For
This is the
antegrade?
procedure. Yep.
Okay. So go ahead.
Okay. So, okay. I want to the wire direction to the calcification portion, but not easy.
Is it Gaia first?
Yep. Next one. I will take the. Okay, NGO. What do you think?
It,
A little bit missed or?
it already passed distal cap in the wrong direction. So why don't you use a parallel wire technique with Sasuke?
Yeah. Yeah, maybe the parallel wire is also the one of the option. However, I think the vessel LAD vessel size was not so large. So and also the we can see the some calcified portion. So the if this antegrade approach, I think it's better to change it into the retrograde approach.
Okay. Show us retrograde approach.
Okay, so but anyway, I will navigate again antegrade one more time.
That may enlarge the force lumen size. This my preference is always use Sasuke and first wire as a guide landmark. I tried second wire.
Right.
Of course, you want to save that diagonal after the at the distal cap.
Okay.
Engage into the LAD ostomy is very difficult. This is right case to use multi-channel guide catheter.
Dual lumen.
Yeah.
보이죠? 마이너스 좀 잡고. A little bit different directions. I will check rest of the time. Okay, 이제. Okay. Tip portions a little bit missed.
So BK, is your retrograde microcatheter in the septal channel already?
Right. So
Yeah, so
actually,
when you
the
inject,
danger
you
was-
can actually
yeah.
do super selective injection to save contrast.
Okay. So just before broadcasting, so I successfully retrograde the wire system, but after changing of the wires, is a RCA system a little bit removed.
Okay.
I will check again.
아이고.
Oh.
when we do this injection, we have to make sure the backflow is very good and also the injection power.
So, because just before I checked again this system, but I did not regurge again.
The retro microcatheter always bounce. There's, sometimes it is a little bit behind. That is safe. But it advances a little bit forward, it may induce
Retrograde
damage like this.
Dr. Kao, do you need hemostasis by straw? Do you need hemostasis with this perforation by straw?
Yeah, I will. I will apply negative pressure on this microcatheter.
But you already, he already wire into the LED. Maybe the perforation side is covered by the microcatheter.
No, this was
another one?
Before, right? You are showing us image.
Oh, really?
Before, yeah.
Really?
Yeah.
So, yeah.
Positive.
Oh, BK, why?
Yeah, so and then I changed the microphone.
You put into the microcatheter to the LED.
Right. 10 minutes ago. Positive.
Therefore, these.
That time you're almost successful.
Right.
아깝다 됐어요.
And also, then this hematoma can be created not by the injection, but by previous wiring and the maneuver, not the injection.
Right.
Okay.
So, in this situation, what do you think? This septal channel, can we use one or so we use the different one?
The related view, the perforation site is separate the true lumen, not? We can see the perforation site and another direction we can see the true lumen, right? Could you show the area?
Previous image.
Yeah, this is the area. Yeah, this is the
Previous image.
No, this is live image.
Alive? Okay.
Yeah.
Then once again, TB injection.
No.
Totally different site.
I think the tip direction can create more.
Show us the previous one, the one with the hematoma.
Could you show the previous one?
Minus 2.
Yeah, this one.
This is the cranial view. Okay.
So you didn't change the position of retrocatheter?
No, I think the position is the same.
Change. I just change the angle.
Yeah, just the angle.
Okay.
But personally,
this is the
personally, I would not use this septal channel anymore.
Yeah.
Even though, like Otsuji sensei said, from the lateral projection, the hematoma seems to be outside or anterior to the channel, but I think it's still too dangerous.
Okay.
Okay. So if that, anyway, because of the time limitations, so now I think it's time to change it over the parallel wire technique integratedly.
Yes.
And then I will check again, very gently, is the some we can see the some another septal channel we can see one. 사수해 주세요. 본론 주시고.
Yeah, in my personal opinion, I want to perform channel wiring.
No, not now.
Yeah.
And also maybe apply some negative pressure on the microcatheter, so that you can straw and maybe collapse the hematoma.
But Dr. Hamazaki's opinion is kind of reasonable, because in my experience, if we just lost the retro microcatheter inside a microchannel, it is easy to reintroduce. Thus, there is some formed channels, dilated channels by introduce and retrieval of the microcatheter. If antegrade parallel wire technique is difficult, then he should find another septal channel. If that is not available, he can cautiously try SAW3 with this retrograde microcatheter. It may luckily pass through the ruptured microchannel into the right direction.
이거지?
Okay, Byeong-Keuk Kim, we
Okay.
are going to listen to the featured lecture first and then come back you again, okay?
Okay.
Okay, we are going to hear the featured lecture 1, CTO Revascularization, Guidelines and Concept Change by Dr. Jung-Min Ahn as a medical center.
Thank you, Chairman. So my topic is CTO guideline. So actually, I'm doing some CTO intervention, but I'm not, frankly speaking, I'm not the expert in the CTO intervention. But many CTO experts were organized, many established many the CTO crossing algorithms and list to 6 or 7 algorithms. In addition, contemporary CTO PCI success rate is more than 95%, particularly Japanese society CTO PCI success rate is, I think, almost 100%. Even though there is data for the opening CTO saved lives, based on the registry data, the future success patient mortality is lower than CTO PCI failure patient. Multinational CTO registry, single center CTO registry, UK registry consistently demonstrated that the failed CTO was associated with worse survivor and successful CTO associated with a better survivor. So 2018 European guideline CTO intervention considered as a 2A indication. 2A means it should be considered. For 2021, 3 years later, CTO guideline a little bit downgraded to B. So the benefit of CTO PCI to improve symptoms is uncertain. Why? This is based on at least 4 randomized trial. So I'd like to start with the role of PCI. In HCS and STEMI, non-STEMI, the role of PCI is to reduce the death or MI. But in a stable angina, major goal of PCI to be angina relief. Based on at least 3 randomized trial, Courage, Fame 2 ischemia trial, there was no difference regarding the mortality, PCI versus medical treatment. But I want to emphasize the benefit of PCI in stable angina. In this study, crossover rate is up to 51%. In addition, consistently, the PCI reduced the spontaneous MI up to the 30 to 40%. But the CTO is actually inherently too stable because the vessel are already occluded, so the reduction of spontaneous MI could not be achieved. So ischemic extended follow-up study, mortality difference was not observed. So my interpretation is like this, based on the registry studies. A successful CTO improved patient survival. I don't agree with these mentions. Instead, CTO failure was maybe decreased patient survival because the CTO intervention always associated with the complication, population, such like that. This is a summary of complication rate. Technical success is almost more than 90%, but cardiac tampon, any kind of complication associated CTO intervention is 14%, 15%. So somebody asked our society to make us some randomized trial. So we designed the decision CTO trial almost 10 years ago. This study, initially tried to enroll the 1,600 patients, but due to the slow enrollment, we stopped the patient enrollment after enrolling the 800 patient. This study, we randomized a patient with a CTO, any one CTO, up to 2 CTO, CTO PCI group and medical treatment group. And after randomization, we treated the non-CTO PCI first and CTO PCI. We compared the CTO PCI versus medical treatment up to 4 years. There is no difference regarding clinical outcomes. In individual clinical outcomes, death, MI, stroke, any repeat intervention, no difference between CTO PCI group and no CTO PCI group. In addition, quality of life, EQ5D, the CTO group better, or treatment satisfaction, CTO group better. But physical limitation, angina frequency, QOL was not also is not different was not different or not different between medical treatment and CTO intervention. Another randomized trial is a neuro-CTO trial. This trial, after non-CTO PCI, they did randomization and 2-to-1 PCI with the DES and OMT versus the OMT. So contrary to the decision CTO randomized trial, in this trial, the physical limitation, angina frequency, quality of life improved by CTO intervention. But clinical outcomes, compared with the OMT, PCI did not show the better clinical outcomes regarding cardiac death MI. So another 2 studies using the surrogate endpoint, MRI assessed the LV ejection fraction improvement at 4 months in STEMI patient with CTO randomization, CTO PCI, and medical treatment explorer trial. At 4 months, MRI didn't show any difference regarding LVEF difference. Another study, Revascularization, evaluated the change in segmental wall motion at 6 months, but no difference between CTO intervention group, no CTO intervention. So the 2021 ACC guideline, in patients with suitable anatomy who have refractory angina on medical therapy after treatment of non-CTO regions, the benefit of a PCI of CTO to improve the symptom is uncertain. Why they mention like this very negative comment. Enthusiasm for treating these lesions are fueled by retrospective data suggesting improved outcomes for those patients who underwent successful recanalization compared with those who had failed. However, RCT have not demonstrated improved function and have not equivocal with regarding symptoms based on the full randomized trial. So however, fortunately, this year TCT new data was presented a combination data set from the decision CTO and Euro CTO randomized trial. Two PIs, Gerald Warner and S.J. Park. So pooled analysis of all patients randomized to OMT or PCI from Euro CTO and decision CTO on source databases, including only patients who were randomized to the one CTO regions, excluding those receiving the concomitant non-CTO PCI 6 months before and within 3 months after inclusion. Primary efficacy endpoint change in angina, EQ5D, and safety endpoint was cardiac death and non-fatal MI. So they excluded non-CTO PCI patient, only they enrolled the CTO PCI patient, then compared with the optimal medical treatment. So this is a change in the angina. So p-value is significant. The physical limitation, angina frequency, quality of life, and treatment satisfaction, angina stability, marginal significant. But anyway, after CTO PCI, such a kind of angina scale improved compared with optical medical treatment. In addition, more patient angina-free and better quality of life after CTO PCI. But clinical outcomes, regarding clinical outcome, death, MI, no difference. Already numerically higher PCI group, cardiac death, non-fatal MI, and procedural non-cardiac death, ischemic-driven revascularization higher in OMT group, MACE higher OMT because of revascularization, stroke, higher in OMT. So up to 3 years, cardiac death and MI, no difference between the two groups. So this combined analysis from the Euro CTO and Decision CTO randomized trial successfully demonstrated that the benefit of symptom improvement after CTO intervention without compromise the PCI safety. So I believe that in the next the guideline, the CTO PCI to symptom improved is proven and want to be a 2A indication. So another interesting REGIS data show that if there is some ischemia, after CTO intervention, ischemic burden decreased. In addition, the patient with the reduction of ischemic burden that showed a better outcome. So before CTO intervention, objective documentation of ischemia or other ischemia is very important. So there are ongoing 2 randomized trials, ischemia CTO trial, novel CTO trial. They require the objective evidence of ischemia before CTO intervention. I do believe that this ongoing trial give us more information and will change our guideline. Thank you for your attention.
A great talk. Thank you, Dr. Ahn. The second featured lecture is Retrograde Approach in TD-ADR Era. The lecturer is Dr. Satoru Otsuji from Higashi Takarazuka Sato Hospital, Japan. Dr. Otsuji, please.
Thank you, Professor Hyo-Soo Kim. I'd like to talk about this title. So recently, IVUS-guided tip detection integrated dissection reentry, TD-ADR, has been popular in Japan and has achieved extremely high success rate. But this is usually accomplished with the special IVUS, Telmo Antewol, and a guide wire, Conquest Pro 12ST, and is not applied widely outside Japan. Retrograde approach has significantly increased success rate, especially in complex coronary CTO regions, and has an established place in many algorithms. So these are 2 algorithms I would like to show. The main indication for the retrograde approach is proximal cap ambiguity and the presence of interventional collaterals. So the retrograde approach has been done especially in the high complex regions, and however, the overall retrograde technical and procedural success is around 80%. So this data shows the Japanese expert CTO registry data. We decided that the whole independent factor for the success of the retrograde approach. One is the moderator severe calcification, and the other is the Toyohashi and the CC grade, CC collateral channel grade, and another one is the non-septal channel. We can see that this data from the success rate is more precisely predict guide wire crossing failure than JCTO score. But the cumulative failure is 28% and 32% is not sufficient by the overall procedure. So what is the most important factor is that we know that the reason for the failure is the most important factor is the retrograde failure is due to the failed guide wire channel crossing. And this has not been changed how long. And this is the data on the JAK intervention. And we had a collateral channel score that predicts channel crossing difficulty. The one is channel diameter, the other is a bend, and the continuous bend and corkscrew phenomenon. So even though the septal channel, even though the score is immediate, the success rate is around 50%. That may reflect that the complete comprehension of the collateral is difficult by angiography. Channel with a score more than 3 has the lowest success rate, around 20%. Is it worth to try? I don't think so. So the retrograde approach, besides the collateral itself, there are some another reason failure to the successful, another reason successful guided crossing. We know the first attempt channel is the highest success rate, and also the diameter of the collateral channel is the key factor of the crossing the guide wire. As mentioned, Dr. Hyo-Soo Kim before, and also we saw the Dr. Habara case today. The collateral direction is important to crossing the guide wire. This studies exactly show that the difficulty of the right to the left collateral channels. I'd like to show but we have some room for the success of the guide wire crossing and this type of the channel. We usually use a double lumen catheter with well work in cases of difficult channel selection. This is RCA septal channel from to the left. And the other one is septal channel the left to right. We can see some good collateral from the injection from the second microchannel port. And then this method is especially useful for the reduce the perforation, collateral perforation, especially in the epicardial channel. We can see the correct channel by the injection of the second port of the lumen. And this is also the array. And we use double lumen catheter. Only we can use the double lumen catheter in Japan. But in the other countries, this type of the angle catheter is, I think, that's especially useful. The channel selection with a severe angular origin. This is a retrograde approach. How to connect the two lumen. One is a conventional, and the other is a contemporary. And the other is extended reverse guard. But the significant difference is among these procedures. I think the contemporary reverse guard and Gaia 3 is effective. But conventional extended guard, we already created the sub-intima. I think the Gaia or other CIFA wire, controller of CIFA wire, we should not use that kind of the procedure because the perforation risk factor is high. This is the overall efficacy of the complication rate from the largest data. The retrograde success is 7.78 and 80%, and but the complication rate is higher in the retrograde approach, perforation and the MACE and AMI. And also the European data also shows the retrograde approach is complication rate is higher than the antegrade, and it depends on the operator experience. One is the key factor for the complication rate. I'd like to show one case of the TD-ADR. This is LED CTO. This case is treated 10 years ago, and that time the sub-intima standing, and the stent not covers the lesion completely. Then this time, the CTO, the complete occlusion of the CTO with involving the IVAS, and we can see the IVAS in the horse room here. And then we try to the tip injection. This is the wire. We can see the wire direction, the tip direction. And then we can, but this is not in the true lumen because we can see the IVAS. We can see the tip by the IVAS. But after that, clockwise and counterclockwise, we can get the wire in the true lumen. Okay, we can see the true lumen exactly. Then switch the wire to the Hsien and go to the distal lumen. And then the microcatheter can go to the, we can see the microcatheter. When the microcatheter covers the wire, we can see the echo shadow. And then this is the final angio. So this is the early data of the tip detection comparing the Stingray or ADR method. In that case, in this paper, tip detection is success rate of 100%. And they are now continue the registry. They do the, I think that they do the more than 200 cases. We have almost 100% success without significant complications. So the important point is the wire is stay in the vessel. In my conclusion, retrograde approach has been performed in more complex region with moderate success rate. Some dedicated device could improve collateral channel crossing. The critical issue for the region crossing is keeping the wire in the vessel. TD-ADR has a tremendously high success rate, even in high complex regions. There is a possibility that CTO PCI algorithms will significantly change in the near future. Thanks very much for attention.
Thank you very much for your wonderful lecture, Dr. Otsuji. Now, let's get back to the Toyohashi Heart Center. Dr. Habara.
Yes. Can you hear me?
Can you hear us?
Okay.
Okay,
yeah,
we are watching you.
Okay. Yeah, okay. After that, so we negotiated the guide wire for the retrograde is mark. Retrograde is a marker, and antegrade was I step up to the Gaia next 4. And Gaia next 4 全然後これか。いや、Gaia next 4 advance to the so 1個前。Yeah, this is completely looks overlapped. We rotate it. So I advanced the microcatheter distal. But so I changed it so XTR. XTR cannot go to the sort of nice course. So maybe this is a subintimal space. So we decided to change the miracle nursery. And the miracle nursery, and so to check the IVAS, I advanced the 2 balloon proximally. And so after that, so guide wire very easily go distal side because so we dilated at the tight site. And so next, I advanced the microcatheter and so check distal. So that is a 2 lumen. And so IVAS also shows so completely 2 lumen. And next. And so this is a double lumen catheter and cyan black. And so retrograde wire is a marker of the so diagonal, second diagonal. That's why so easily to close. This is a cyan black. Next. And so we check the retrograde, and of course, so we wonder about the perforation of the septal branch. However, this is a little bit enlargement, but no perforation. That's why so I remove the retrograde guide wire. And next, balloon dilatation. This is a 2 to 5 that we use for the anchor balloon technique for the RCA. Next. So that is a very, very tight synoptic region, and we very calcified plaque at the site. So we dilated KVT 225 and 25. 25 is a non-compliance balloon. And so next, this is angiography from antegrade. This is a procedure sulfur.
Yes, the essential point is that you manipulate anti-wire with Gaia 4, but it did the wrong way. Thus, you changed Miracle 3.
But so Gaia next 4 can pass the CTO site. However, so there is a diffuse flux so distally. That's why, so I think that so Gaia and Christopher could pass the CTO segment. However, guide wire migrate to the subintimal space at the distal site of the CTO body.
Thus you changed Miracle 3.
Yeah, and so I advanced the calcium catheter at the CTO body and changed the miraculously. And so miraculously can close it to the distal.
Then wire cannot be easily passed. Thus, you did anti-ballooning.
Yeah, anti-ballooning.
After ballooning,
yes.
the wire passed. What's the reason?
Yeah, I think that so, proximal site is a very tight region, and maybe so guide miraculously a little bit coming to the proximally, and so I advanced to the different course. The Gaia next to four closest to the subintimal space. That's why. Miraculously could be rerouted to the true LED course.
Okay. Anyway, the proximal puncture area is very good. Thus, we can see D1 and D2 right now.
Yeah.
So, what's your summarizing procedure?
Yeah, thank you so much. So we consider further, so this case looks retrograde procedure maybe more better with the septal branch. However, so Dr. Paul suggested that maybe epicardial channel is one choice, I think. However, so I finally negotiated retrograde, but so retrograde direct cross is not so easy because it's a very short segment and completely two different courses. So finally, integrated Gaia and Christopher, as Dr. Otsuji mentioned, so shift wire is better to cross. And finally, that is succeeded for all of them, your suggestion. Thank you so much.
What are you going to do from now?
We implanted a stent from LED to distal LED, and diagonal branch will be DCB will be performed.
Okay, thank you very much for your wonderful live case.
Thank you so much.
Now we are going to Severance Hospital. Dr. Byeong-Keuk Kim, we are back.
Okay. 좀 더 패러럴 보여주십시오. Okay. So the from the -1, minus, 쭉쭉 minus. Okay, 됐어. Also, this is the first wires. Anyway, we can see some calcification locations above the wire, and also area view is a little bit right location. Is we can see some calcification regions. So based on these findings, I used Sasuke. This is the next one. Positive plus. Okay, so this is the first movement of using the parallel wire technique. This is the Gaia next two. Next one. The position is not so bad. Positive. Oh, okay. So this is the retrograde injection. So, however, is the wire tip locations a little bit deviated into the diagonal. However, area of view is a different location. Next one, and then I will. From the retrograde injections we already obstructed of the using the retrograde corseas there was no further leakage, positive one, and then I will do again with the Gaia next three. However, the wire position is not so good, so I think better to change it retrograde approach. -1. So, yeah. So this is the injection. So maybe during the antegrade preparations, previous retrograde wiring a little bit occurred different location. So I should have more attention. Anyways, that ruptured portion and then the distal portion, we can see some different route. I'm gonna use that channel for the retrograde channel.
Okay, it's good. Go ahead.
Okay.
Luckily, there seems another microchannel
Another one.
beyond the perforation site.
Caudal view. Okay. Cranial view. Cranial view.
Angiogram of septal channels are always misleading. As my personal habit is, I do a tip angio at least at 3 different angles and analyze 3D wise. That is a good my tip to avoid the misled by the overlapped fine microchannels.
I fully agree. 크레니얼 좀 풀까?
Usually, the lower third of the septum is better viewed with caudal.
Yeah.
And the top third of the septum is probably better with the cranial. Right?
Septum is deviated toward RV, like this septum. Thus, from the PDA, septal channel direction is like this. It's very difficult to negotiate, but it is easier. And the later half, from the right to left
카우달.
side.
그쪽 방향으로 간 것 같아.
네.
Thus, even though it looks straight in the simple RAO, if we see the RAO caudal, it is tortuous. Thus, it is very tricky to negotiate septal channel from right to left.
오케이, 와야 가시죠.
Byeong-Keuk Kim, please
Okay.
take your time because
Okay.
we are out of time, so we have to deliver the session to the next team. But we
Okay.
will pursue your final results. So please,
okay. Thank you.
invest
Okay.
without any kind of hurry up. Just pace your
thank you.
ordinary stance. Thank you very much for your
Okay.
wonderful live
Thank you,
demonstration.
Professor
Yep.
Hong, Professor Kim. Thank you, Dr. Otsuji.
Thank you for joining us.